And that's where, when you treat cancer patients, and particularly as they start getting more advanced, you have to undo that. Now the immune system is being controlled by cancer, and you need to try to stop that signal and get it to the immune system not listen to the cancer, and to understand that it needs to be protecting the body. I mean, it's challenging, but that's kind of how it all works.
So basically, what they did is they engineered this tighter binding, and they delivered it intratumorally, and they were able to show that it generated an abscopal effect. Again, local treatment, local immune activation, transferring that systemically. And people go, well, what does the Williams Cancer Institute do? We activate the immune system, but the way that transfers from just a local treatment one time to a sustained, durable systemic effect, it's that abscopal effect that most people misspell because it's a weird word, but it means away from target.
Yeah.
That's it. We activate the immune system here, away from the target, it works as well.
Yeah, it's key, and again, it makes sense. I mean, if you're going to start the immune response, you would expect it's going to start where the cancer's at, right? And then, then it will teach the other parts of the immune cells, and then hopefully they will come in and start attacking. And it's, I mean, again, it's the flaw of cancer treatment to think that you can treat completely externally. Coming in, that just doesn't make any sense.
So basically what you're doing is you're taking the immune system to school. That's what you're doing. You're saying, okay, everybody sit down, chalkboard, here we go, lesson number 1. Bad guy, antigen, go get it. Now, let's bring all in the students and let's go learn and target that. Now, go out and tell all your friends about it.
Right.
And that's exactly kind of what happens with the abscopal effect. So, basically it's something first described in 1953 by Dr. R.H. Moll, actually radiation. The problem is radiation killed everything. But here, CD40 in this study, they're actually able to show one agent injected into a tumor is able to elicit this. But do we inject one agent?
No, we don't. But you have to have multiple agents. CD40 certainly being important base, but you've got to have several things working together. And it's like baking a cake. I mean, like you come there with just eggs. You just have the oil, butter, or whatever. You got once you start getting all together, then you get something different, right?
Or you're lining up for a 45-yard game-winning field goal. You don't have a snapper. You don't have a holder. And you're just sitting there waiting for the ball to be snapped for you to kick the winning field goal. By the way, he was a kicker, so that's why. So then. You can't make that game-winning kick because either one, it wasn't snapped, it wasn't held well, or nobody blocked.
Right.
And then you get blamed as the kicker, right?
Right.
So again, they were able to optimize the strong binding and actually lower the effect. Next slide. But what they were able to find is that basically they ended up in the mouse. They ended up with the same problem because they were delivering it initially systemically, and so they said, well, okay, we got to move to tumor. And so then they use these humanized mouse models. Now, when people think about animal models, etc., of course, mice, and you've used mice in a wide variety of tools. We've talked about some of those stories, how they escaped and stuff. But what's a humanized mouse model? I mean,
so of course, they have different versions, but a lot of it is particularly looking at the antibody side of that. So they're looking at mice that are expressing immune, sort of have an immune type that looks more like human. So that's the part that they're really looking at on that. So that when you're using these immunotherapies, that they would match, even though you're doing it on mice, that it's would match with the human,
right?
And and of course they have lots of different interesting stuff that they can do with these mice, and we've studied mice that we cure the mice. Like we got them all figured out. Humans was what we need to be doing it in. We have the stuff we know, and that's what we're doing, and I think we're figuring out. And definitely humans are more complex than the mice. There's not even a humanized mouse that you can match with that. It's a different deal.
It gets us close.
Yes.
It gets closer. So what they found with systemic administration of CD40 monoclonal antibody was at 0.25 milligrams per kilogram, significant liver toxicity and thrombocytopenia. So same, even lower dose, better binding. And they found, of course, an increased potency, but massive thrombocytopenia. So again, still better binding, lower dose, systemic toxicity, still the issue until they approached the intratumoral approach, which then allowed them to not only keep the dose low, but even lower, improve the safety profile, improve the efficacy, and actually activate that immune system. So really, the answer was maybe a better binding. The answer was a better dose, but the answer here really for CD40, that Swiss Army knife, it was delivery.
Yeah. Certainly, you can do all the things to make the the antibody a little more specific and bind better. But the real key thing is that putting that agent, activating that receptor at the tumor site. You can get by with some that are less, they could, as far as like they don't have as much off target effect because you're putting it at the site. You're not going to get that off target.
And what you're going to see is as a lot more people start to get the aha moments here and go, Eureka, I get it. It's important to understand there was one person that was really leading the way in that intratumoral approach. And it is this man sitting right here, Dr. Jason Williams. That's why I left leading the clinic that I was doing, because I knew that he was already introducing and using the future of cancer care today. And so what I wanted to do was join with him and be a part of what the future was and expand that to more patients. So as you start to hear more about this, remember who the quote unquote father is, and that would be Dr. Jason Williams. So basically what this is doing, Jason, is it's create, a lot of people, let me back up, a lot of people will say vaccine.
Yeah.
Right. And what happens in people's minds, they get this kind of political, argument in their head. But basically what this is generating is an autologous in-situ vaccine.
Yeah, you're doing what you need to do to get the immune system to see and attack that cancer. In a situation with a virus, which is simpler, you just have the pieces and you put it in there, and that's your vaccine. But with cancer, much more complex, a lot of things going on, and so it's it's a little different. But it is the same concept where you're trying to get the immune system to recognize that cancer and attack it, and then you're essentially you are vaccinated at that point against that cancer, and that particular cancer, the person should be theoretically protected from that. Yeah.
And so a lot of people will say, well, I'm getting natural killer cells injected. I'm getting dendritic cells injected. But does that necessarily create a vaccine?
No, the problem is that's not a good option. I mean, it's like, sort of saying like you got a war going on there and you're going to throw some troops out there, and you're not even telling which side they're going to fight for. They're just going to make their own decision. I mean, that's what you're doing. You're adding these soldiers there that are not prepped as well. I mean, some of them, they try to get them, obviously to try to be, more able to attack the cancer, but it doesn't have all the signals. You have to have the other signals. I think, that's a real key. Just the immune system will do it. You just need to do the right signals. You don't have to try to make more of these cells.
Right.
You can make the cells work and do it, and they'll take over.
What I often say, Jason, is it's like a relationship. When a relationship is working well, like here, what we're doing, there's good communication.
Yeah.
Now, if communication breaks down, guess what? There's problems. That football teams, obviously I love football, so it's about to start. So, this tomorrow's first football game. So if the quarterback gets up there and he doesn't communicate effectively, if the offensive line doesn't communicate effectively, guess what? The quarterback's going to get his head taken off.
Sure, yeah.
So there has to be that communication, because all the pieces move together to get a first down and a touchdown.
Yeah.
So what you're saying is the pieces are all there.
Yeah.
The issue is the communication.
Yeah.
And cancer recognizes that.
Yeah.
And it recognizes that. It's interesting because people use that word vaccination, and I love looking at words. It simply means that which pertains to a cow.
Yeah. Right. Yeah.
So, obviously we're not talking about cows here, we're talking about, probably a better word, inoculation,
Right.
which means immune activation. And that's really what this internal activation of the immune cells that are there that are being provided by the intratumoral approach.
Yeah.
It's creating a specific, personalized, precise inoculation that elicits a vaccine.
Yeah. Yeah.
So basically what they did in this phase 1 trial, so humans, they looked at 12 patients, and melanoma, breast cancer, and renal cell carcinoma, a mixture of them, mostly breast cancer, but they'd had prior treatments, and they had, of course, wide metastatic lesions. They received, actually, interesting enough, Jason, 4 different doses.
Yeah. Yeah.
4 different doses. Go ahead, next point. They looked at 0.7 milligrams, 2, 7, and 10 milligrams. Get this,
Yeah.
they administered them every 3 weeks.
Oh, yeah.
How often do we typically
3
administer?
weeks. Yeah.
Yeah.
It's very interesting. Yeah.
And how long have you been doing that?
Yeah. For a while.
Yeah, so it's, again, welcome to the party. Welcome to the party. It's great. So they found no dose-limiting toxicities. They did not reach the maximum tolerated dose. All the adverse events were only mild, grade 1, grade 2, which interestingly enough, they had no grade 3, grade 4. This almost lines up exactly with the SYNC-T data update at ASCO in May.
Yeah.
And they had no of the thrombocytopenia, really low platelets or the autoimmune hepatitis, so they had none of that. So basically by delivering to the tumor, even at the high dose, the 10 milligram.
Yeah. Yeah. It's
well tolerated.
Decent enough dose. Yeah. Yeah. I think it's interesting because initially when I was doing the work, I was looking at the mice, the mouse studies, and I tried to think of okay, how do I adjust the dosing? I know what the dose they use in mice, they did all this different stuff. So how do I figure out, well, how should I adjust that in humans? The reality is that even though the tumor is small and the mice are small, and that's a small dose, you can get activity even with very, very low doses. Of course, we found that we understand a little better now the range of dosing that you need to do. Certainly, it's on a grand scale much lower than your systemic dosing. I mean, I would say on average, you'd say if this drug if you're going to use 400 milligrams, then maybe 10% would be your max dose, right? 40 milligrams. But could you get activity with 5? Could you get activity with 10? Yeah. Certainly, you can see it. I mean, you can see. I've seen it with certain cancers using multiple drugs at 1 milligram levels, and getting amazing activity with super low doses across the board.
Whereas conventional medicine says, let's give a big dose, let's give it systemically, and try to get that work. So they saw no dose-limiting toxicities. Again, they didn't achieve the maximum tolerated dose. Very mild injection sites, no grade 3, no treatment. So conclusion, intratumoral is the way to go. Intratumoral is the way to go. Now, interestingly, then, when they looked at clinical outcomes, they were only able to, evaluate 10. So 2, whether they were lost to study or whatever, I don't know. But they found 20% of the 10, or 2, had overall response rate where they achieved complete remission.
Yeah.
So 1 was melanoma, 1 was breast cancer, again, stage 4. All they did was inject CD40.
Right, yeah.
That's it, a monoclonal antibody.
Yeah.
But of the remaining 8, 6 achieved stable disease.
Yeah.
So sometimes I think people go, well, cancer's growing rapidly, it's out of control. Sometimes the first step is actually stopping it in its tracks and making it stable.
Yeah.
And then now get the immune system to turn that tide.
Yeah. Yeah, because basically, when you look at aggressiveness of cancers, you have the super aggressive cancers are growing fast. The immune system is very actively helping that cancer grow.
Yeah.
And then, but as you look at the level of help of the immune system, then that changes how fast the cancer grows. If the immune system is somewhat attacking, okay, now cancer's grow slower. And so, anything that you can do to get the immune system to at least try to be after it, and maybe it's not successful at getting rid of it, that's going to start slowing it down.
Well, it reminds me of the patient today, Paul. He was asking about, well, what have we seen? He had 1 treatment, stage 4 pancreatic cancer, and he wanted to know, well, have they shrunk?
Yeah.
No, but they hadn't grown, but yet the characteristics of those tumors had changed drastically.
Right, yeah.
Which means what we expect to come
Yeah.
is they shrink.
Shrinkage, exactly.
Yeah.
Yeah.
So what they found, though, is in those that responded, 100%, there was the abscopal effect. Now, this was a melanoma patient, 54 years old, stage 4. He had prior progression on anti-PD-1 therapy. Now, we see that, right? We see that where people progress on systemic, and then you inject it, and voila.
Yeah, that's the difference.
Multiple cutaneous, subcutaneous metastasis, 1 lesion was injected. Complete regression of injected lesion by 8 weeks, progressive regression by week 16, complete response confirmed at week 24, with a durable response at this point of the publication, 18 months.
Yeah.
Reminds us of some of the patients we see.
Yeah.
So CD8 T cell activation, tertiary lymphoid structures that developed, cytokine profile that is favored anti-tumor rather than pro-tumor, and the development of tumor-specific T cell clones, both in the tumor environment and peripherally. What's a T cell clone? I mean, in terms of, because it's not just a local immune activation, but a clone is something that it gets sent out and starts to do the same thing outside.
Yeah,
right?
so then you get the propagation where the T cells are attacking it, but they're cloning, and you're getting more and more of them. Like it's like you got your soldiers there, and then all of a sudden imagine they can start like doubling, tripling, and you get more and more, and that's kind of what's happening with the T cell clone.
So it's kind of like a virus that's cloning itself, replicating, and honestly, in a way, cancer. But here, it's a good thing.
Yeah, the T cells that are attacking that particular receptor. That's the thing. Is that
that's true?
That's
true. Good point. Good point. So now, what they again found was the tertiary lymphoid structures, which are going to organize kind of ectopic lymph nodes. And so essentially the way I look at it, it's kind of like a super highway with an on-off ramp right there by the tumor. So that when the tumor cells are destroyed and antigens are created, the immune system being recruited, there's an on-off ramp right there for that process to just create a nice, beautiful cocktail.
So this is one of the things that, interesting. I was doing some work at Case Western, and I just happened to, one of the graduate students was doing a study, and he was doing on autoimmune disease. But what he was looking at was these on and off ramps of like the immune system, because how do the immune cells get to the tumor? Or in this case, they were looking at autoimmunity, but it applies to the cancer as well. And so cancer, when it's building its area, it's making sure there's no off ramps for the immune system, right? There's no train stops for that. They want to try to block it out, and cancer does it specifically. So that's you have to change that environment around it to try to be able to get the immune cells there.
So then let me ask a question that gets asked to us a lot. And a lot of patients, I'm sure, watching this or listening that would ask, what about where lymph nodes are actually surgically resected? You're taking out the on-off ramps right there.
Yeah.
Now, I understand it's to reduce tumor burden, but what if that now tumor locally recurs? The on-off ramps have been surgically removed in a way, which compromises immune function, which is, I think, why if there's local recurrence and that lymph node dissection has been done, then basically now you have the process where it's really hard for the immune system to get there in a way.
Yeah, I think, unfortunately, surgery and any cancer is probably a bad idea, and certainly removing anything is a bad idea, and removing the lymph nodes could be problematic. And so, but
like you said, those parts were created for a reason, and they need to stay there as much as we can. As much as we can.
Yeah, better to fix them.
That's right.
That's right. Take them out.
That's right. Fix what's there. Heal what's there. Heal what's there. Yeah. So different areas in the tertiary lymphoid structures, they can be peritumoral, intratumoral, perivascular, adjacent. So the point is they're really key to this immune response. And I think one of the things I want you to take home here is that these therapies being combined together, as Dr. Williams has developed them and seen what's worked and gone through the science, there's an intent and purpose behind them. When you look at conventional oncology, and even when you look at a lot of what happens in integrative oncology, or quote unquote natural, people are just throwing things on the wall, protocol, and hoping they work. Yeah. But everything that we're doing is with great design and great purpose. As you said, it's art. The science is foundation, but And people would describe medicine as an equal part of science and art. So there's the science, you have the working understanding of the science, but what you're also perfecting is the creative application of that science to be effective.
Yeah, yeah,
And that's what you're doing.
right, yeah.
So I love this, and we're going to put this slide on the video, so I encourage you to check this out. But basically, when we get high antigen availability and we get high T cell activation, we get antigen presentation in these tertiary lymphoid structures, and we're going to get the abscopal effect. So basically what we're doing, and you'll see this on the presentation, if you're just listening to it, I encourage you to go watch the video, you'll see this here. It's shifting it into that basically upper right, far right area where we're getting local immune activation, transferring systemically, but it's because of a clear, creative, artful application of that science. And here we're just talking about one agent, CD40, monoclonal antibody. Man, what if they had just added PEF with this? I wonder how much better it would have been. Instead of 2, it could have been 4 with complete remissions.
Yeah, a lot of stuff, yeah. You know, obviously there's many things that could have been added to it to make it better. You know, and unfortunately, I know how they'll do. They'll look at it and say, well, this works really well. They'll look at that one drug and they'll try to do just that. And obviously that's a nice weapon, but you need all of them together.
Yeah. And by the way, just a little bit behind the scenes, we get together as a team and we talk about patients that are doing well, patients that are not doing well, strategies to change, strategies to adjust. And then before procedure, we're actually sitting there looking at the images together and talking about how to target, how to better coordinate activity with therapies to target these tumors. So the proposed mechanism here is the initial local effects, activating via the CD40 monoclonal antibody, upregulating co-stimulatory factors, increasing antigen presentation, producing pro-inflammatory anti-tumor immune response. Remember, simply stimulating the immune system and stimulating inflammation does not equate to good or bad. It must be directed, it must be communicated, and that's what we're doing. Creation of tertiary lymphoid structures, the development and the creation of priming the T cells, and then that's then generating that systemic immune response. So you're creating a predictable, reliable, reproducible abscopal effect.
Yeah. Yeah.
And that, in a way, that's what the Williams Cancer Institute's perfected.
Yeah.
It's taken something that people would go, wow, that's interesting. It helped there, but it doesn't help all those.
Yeah.
You've been able to say, well, here's how we make it so that it helps all these.
Yeah. 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 You know, you have, you know, cancers are all different. People are different. Their immune responses are different. You know, so you come up with a strategy. You start seeing, okay, these cancers do well with this combination. These do well with this, and you start trying to put that together. And then you have others where, yeah, you have to watch and see. And then, you know, what you do is then you try to figure out, okay, well, you hit it with that. What is it doing? Okay, maybe we need to consider this, maybe, and just try to make adjustments, you know, and try, you know, that's the only way that we can improve the therapy.
Yeah, it's like a timeout. It's like halftime.
Yeah.
It's like a courtside, you know, timeout. It's a lot of different things.
Yeah.
So
in the tech industry, you know, they have this thing they call fail fast. And, you know, it's kind of the same type of thing where it's like you're retreating and you're seeing, okay, it's not working. You don't want to just keep hitting it because that's what happens with normally chemotherapy. Where they say, well, we'll get it to you and we'll check you out in 3 months, right? No, that's too long. I mean, you want to know. And so that's what, like with the procedures, is kind of nice because we're scanning, you know, particularly, you know, typically that we're doing 3-week intervals. Occasionally it's 2. Certain cases might be 4. But, you know, so you're looking each time and you're saying, okay, is this doing something?
Yeah.
You know, and then if you know, I look and I'm like, you know, because it happens commonly. I'll hit a cancer with something and like, this cancer didn't look like it budged.
Yeah.
And I'm like, we've got to try something different.
Yeah. Well, like for example, today, what did we saw? We saw a bunch of evidence in that tumor that was treated 3 weeks ago, roughly.
Yeah.
Where it looked like it was starting to develop some necrosis, liquefaction. You know, it was just not solid.
Yeah, that, you know, in the case like today, it was a good one where, you know, we're like, we know, okay, this therapy is working.
Yeah.
We're on the right track. We're going to stay with that. If something changes, we'll adjust. But, you know, that's you know what it is. But yeah, that's the nice thing about having this, where you're constantly looking and but also to be able to be adaptive. I mean, you're not saying we're just going to give you this one therapy and that's it, and see if it works or not.
You can't do that. It's not protocol medicine. So what they found is direct tumor injection, localized high concentrations, minimal systemic exposure, toxicity, favorabilities of a safety profile, enhanced tertiary lymphoid structures, and only systemic effect was the robust abscopal effect. So basically, it showed the ability to generate a immune response that was precise, but against really heterogeneous antigens. So again, that concept of epitope spreading that was mentioned at the ASCO in response to the update presentation. So benefits were enhanced safety. That's always a win because this therapy, as you've mentioned, was not tolerable from a systemic approach.
Right.
When do you think, Jason, that the research is going to start pivoting from, well, maybe we shouldn't be trying all these clinical trials in systemic. Maybe we should try some of these in the tumor.
I don't know why. It's been, a long time ago, right? I mean, it makes sense. I mean, that because that's actually what you do, or initially like in cell, because you get all these stories and this hype that, oh, we injected this in the cancer, it kills all the cancer. And then you see that, everybody's like saying, oh, this drug kills all the cancer. Well, yeah. There's a lot of things you can inject into a cancer and kill all of it when you inject right into it.
Right.
That's a whole different deal than when you start looking at, in the animal. But then let's say you look at the mice. Well, again, that was the thing that I saw. In my research, we did stuff where we injected stuff in the tail vein, which would be like intravenous. Didn't work. We inject the same drug in the tumor, it works. I'm like, well, that right there shows me the difference. I mean, and so that's why I thought it was so obvious. And that was in 1994. So,
so a little bit while ago.
Yeah.
A little bit while ago. So then that created the autologous tumor vaccine effect, generated the tertiary lymphoid structure, again, the local immune priming, and then that generated the abscopal effect. So they're basically saying this is the framework by which this one intratumoral monoclonal antibody, CD40, activated the immune system. Not just the what, but the how it did it. Mm-hmm. And I think that's why this is so important. This was, I think, a very important article, and I think it's going to be a sentinel article moving forward in systemic versus intratumoral. But the reason why this is so important to discuss here is because your innovation, the Williams Cancer Institute, what we do, it's already led the way with this in the news real-time publication.
Yeah.
I mean, we've been there.
Yeah.
We've been you've been perfecting. Now, I mean, part of it, we're working to perfect this. Yeah. And this is the future of cancer care, but we're already working on the future of the future.
Yeah. Yeah. I mean, it's nice to see that other people are seeing it, and obviously they're way behind and they're not where we're at. But it gives further validation that other people are doing it. And that makes me very happy to see other people involved in it.
And you don't get jealous, right? Because welcome.
Oh yeah. The more the merrier, right? Yeah. I mean, you bring it on. We just want people to, because again, this is a team effort. We're working together to try to save cancer patients. Whoever comes up with it, whatever they come up with it, we could use. It's great, and the more people that are doing the things that help us, that's just more information for us. I mean, we have great colleagues that are already working intratumoral, and we have our group. We're a very small group of us. Most of them are more in animals. Mm-hmm. And but I work very closely with those people, and I always talk with them, and they tell me what they're seeing in the animals, and I say, okay, well, we're seeing the humans, and a lot of times we have a lot of stuff that's interesting in the humans, and it's just a great process to be able to work together.
So I mean, here's the thing: they talked about challenges. They said, well, we don't know exactly. Actually, go to the next slide. The challenges that they mentioned was we don't know the right combination.
Yeah.
Okay. And what I hope that they do, if you know these authors, again, check out the show notes, reach out to them, have them contact us, have them contact Jason Williams, and he'll be able to provide some nice insight to how those Because they talk about immune checkpoints together.
Yeah.
They talk about chemotherapy in combination. They talk about radiation in combination. We work with all of those,
Yeah.
meaning the chemotherapy and radiation being done by their local oncologist, but immune checkpoints as a part of the CD40 agonist as a combination? Oh, yeah.
Yeah, I mean, there's a lot with that, and certainly we know that certain cancers, I mean, you've got certain drugs that work really well, but like with some of the ones with the checkpoints, there may be a situation where early on in the cancer treatment you don't want to use those because that might actually give a negative signal to the immune system, and maybe the cells there are not responsive, so you need to kind of change that. Then you want to switch into those agents. So there's sometimes a timing issue. That all depends on the cancer, and we're kind of have an understanding of which ones we can't really hit with the checkpoints up front, and others you can get by with it, or works well.
Now they're moving on to phase 2.
Yeah.
They're injecting glioblastomas at the time of surgery,
Yeah.
bladder cancer, and I thought that was interesting. We talked about this today over coffee. Prostate cancer.
Yeah.
And so SYNC-T trials where
Right.
the
SYNC-T's
result
already way more advanced than that because it's 4 agents.
I know.
So
87% response rate 1 year.
yeah.
Metastatic castrate-resistant prostate cancer, 53% remission.
Yeah.
So, but it was a combination of 4 plus cryo, and here they're just using 1.
Yeah. We obviously when we developed the SYNC-T drug, it was very strategic. I mean, we looked and saw and had different things we tried on patients and try to say, okay, this regimen works, and and we knew from the FDA standpoint they would allow us the 4 drugs because initially when Synchromune was formed and the doctors were talking with me about what drugs you want to use, and I was like, well, I've got a great one. I've got these 8 drugs, and they're like, I don't think the FDA
Too much bite off.
Yeah, the FDA's not going to let us do that, and so they're like, you got 4. Which ones are they? And so it was we had some meetings and discussions and figured out, okay, if we only got 4, these are the ones that we're going with.
So it's not which 3 things, if you're stuck on a desert island, and which 4.
Yeah.
Which 4. So basically, here it's, okay, now what we need to do is figure out how to create a durable response, but how to use in conjunction with intratumoral therapy. Now, there was a 2018 study here where they actually used it in humanized mouse models, combining with anti-PD-1 therapy, and they found synergistic anti-tumor effect, higher complete response rates, more durable immune memory, and enhanced tertiary lymphoid structures, which is actually what was being shown in that update on SYNC-T trial presented at American Society of Clinical Oncology in May 2025. So, so that you're showing that in real time with people with prostate cancer there, and we fully expect to see that in other cancer types.
Oh, sure, yeah.
So the broader implication, though, here is converting cold tumors hot, which ablation does that as well, creating the autologous vaccination, inoculation, immune activation, and then triggering the local treatment that transfers systemically the abscopal effect. So these are the broad immuno-oncology perspective described in the study that is being expanded and being really taken to all cancer types at the William Cancer Institute. And so safe, clinically effective, we understand the mechanistic insight, and now the therapeutic potential is alone CD40 agonism, obviously is powerful, but its sweet spot is in combination. That's its sweet spot. That's its sweet spot. So this, this study, I encourage you again, read it, I say that over again, check out the show notes, because it was just published last week. Here we are, May 22nd, August 22nd, 2025. May, I have no idea why that came from. Whew, I'm a little bit behind. So it was just published last week. And we were in fact asked to write a comment on that study, but yet when I saw this study and when I read it, I just smiled. Because it knew that when I knew Williams Cancer Institute was providing the future, and what I always tell patients is we're providing the future just today, this study is saying yes, today.
Sure, yeah.
So it affirmed that we are providing the future and we're still way ahead of where they are, but we welcome them, congratulate them on their great research. But welcome them to the table, because the more collaborators, the better, the faster, the broader the treatment strategy that can help patients.
Yeah.
And that's what, because this is something people don't know about you, Jason. You got a big heart.
Yeah, sure, yeah.
You got a big heart.
Yeah.
You have a lot of patients that say, hey, I need some help. And you always come through.
Try to.
You always come through. And that's something that you don't see behind the scenes. I'm going to try to get some, time from time, some shots behind the scenes, because it shows who Jason Williams are, who we are as a team, and what you really get when you come to the Williams Cancer Institute. So thank you for joining us on this podcast where we discussed a current event, a recent publication, and how that's applicable to the leadership being provided at the Williams Cancer Institute. Jason, where can the followers and listeners find out more about us?
Yeah, so certainly williamscancerinstitute.com,
Yeah.
our website. It should have everything on there.
Now, they can also find you on X, right?
They can.
Yeah. So check out, you're going to be seeing a lot more information, a lot more commentary from Dr. Williams on X. And hopefully someday you'll be able to engage on there very, very soon in the Spaces platform with other experts in the arena.
That would be great.
Yeah. And so then you can hop in there and listen in close and personal. So join us on the next podcast where we'll dive deep in with other experts, but here always bringing Jason Williams on to describe the Williams Cancer Institute and what we're doing to change cancer care today and tomorrow. Thank you for joining us. Share, like, and subscribe, please. And I encourage you to always join us on the next podcast.